Gastrectomy is the removal of part or all of the stomach. There are three main types of gastrectomy. A partial gastrectomy is the removal of a part of the stomach. The lower half is usually removed. A total gastrectomy is the removal of the entire stomach. A sleeve gastrectomy is the removal of the left side of the stomach. This is usually performed as part of a surgery for weight loss. Gastrectomy, partial, distal, with gastroduodenostomy. With gastrogenostomy, the physician makes a midline abdominal incision. The distal stomach, antrum, is dissected free from surrounding structures and the blood supply to the antrum is divided. Next, the gastroduodenal junction is divided and the stomach is divided in its middle portion, removing the antrum. An anastomosis is made between the proximal stomach and the duodenum or jejunum with staples or sutures. The incision is closed. Gastrectomy, partial, distal, with formation of intestinal pouch. The physician removes the distal stomach, antrum, and performs an anastomosis between the stomach and a pouch formed of jejunum. The physician makes a midline abdominal incision. The distal stomach is dissected free of surrounding structures and the blood supply to the antrum is divided. The gastroduodenal junction and the middle portion of the stomach are divided and the antrum is removed. The proximal jejunum is divided and the distal end is folded upon itself and approximated in such a way to form a pouch. The pouch is connected to the proximal stomach and the proximal end of the divided jejunum is connected to the jejunal limb distal to the pouch anastomosis to establish intestinal continuity. The incision is closed. Gastrectomy, total, with formation of intestinal pouch, any type. The physician makes a midline abdominal incision. Next, the stomach is dissected free of surrounding structures and its blood supply divided. The stomach is divided at the gastroesophageal junction and the gastroduodenal junction removed. The proximal jejunum is divided and the distal end of bowel is folded upon itself and approximated in such a way to form a pouch. The pouch is connected to the esophagus. The divided proximal jejunum is connected to the limb of small bowel distal to the esophageal anastomosis to restore intestinal continuity. The incisions are closed. Pancreaticojejunostomy, side-to-side anastomosis, pusto-type operation. The physician creates a pancreaticojejunostomy to drain pancreatic enzymes through a side-to-side anastomosis. The physician makes a midline epigastric incision and retracts the skin and underlying tissues laterally. The physician approaches the pancreas through the lesser sac of the omental bursa or through the transverse mesocolon. A jejunal loop is brought up to create a fistula for enzyme flow to the digestive tract. Bleeding is controlled and the lesser sac is closed. Tissues are proximate to the anatomical position and the incision is sutured in layers. Ileostomy or jejunostomy, non-tube. The physician brings a loop or end of jejunum or ileum through the abdominal wall onto the skin as a stoma. The physician makes an abdominal incision. Next, the selected segment of jejunum or ileum is isolated. A loop or end of the selected segment of bowel is secured through a separate incision on the abdominal wall onto the skin as a stoma. The initial incision is closed. This stoma is created for purposes other than enteral feeding. Colostomy or skin-level cecostomy. The physician performs a colostomy or skin-level cecostomy. An abdominal incision is made and the peritoneum is entered, followed by a thorough exploratory exam of abdominal organs and tissues, including lysis of any adhesions. The small bowel is mobilized and isolated out of the way. The distal bowel is measured for the appropriate length for pouch creation. A proximal point from the distal end is separated from its blood supply to be made into a pouch nipple valve. The pouch is fashioned into the right configuration and secured in place. The nipple valve component is intussuscepted and secured in place. The pouch end of colon, or cecum, is brought out through a separate incision on the abdominal wall onto the skin as a stoma, cecostomy or colostomy, and secured in place with a pouch nipple to mucocutaneous tissue anastomosis. The abdomen is irrigated, a final inspection is made, and a closed system suction drain may be placed. The abdominal wall skin is closed and dressed and a pouch intubation catheter is placed into the nipple valve and pouch. Colostomy or skin-level cecostomy, with multiple biopsies, e.g., for congenital megacolon. The physician performs multiple biopsies of the colon wall and brings a loop of colon or cecum through the abdominal wall onto the skin as a stoma. The physician makes an abdominal incision. Next, multiple biopsies are obtained along the length of the colon wall. A loop of colon or cecum is brought through a separate incision on the abdominal wall onto the skin as a stoma, colostomy or cecostomy. The initial incision is closed. Gastrogenostomy. The physician performs a gastrogenostomy. The physician uses an upper midline epigastric incision through fascia and muscle. The distal end of the greater curvature of the stomach is removed. The duodenum is mobilized and connected to the greater curvature. The anastomosis is closed with interrupted stitches and the abdominal incision is closed. Gastrogenostomy, without vagotomy. With vagotomy, any type. The physician performs a gastrogenostomy to create a direct passage between the stomach and jejunum. The physician makes an upper abdominal incision to expose the stomach and small intestine. The distal portion of the stomach is resected and the jejunum is anastomosed to the gastric stump. The duodenal stump is closed. The vagal nerves are preserved. Report 43,825 if a vagotomy is also performed. Gastrostomy, open, without construction of gastric tube, e.g., stam procedure. Neonatal, for feeding. The physician constructs a temporary or permanent gastrostomy for installation of nutrients. After making a midline incision in the upper abdomen, the physician chooses a gastrostomy site on the middle anterior surface of the stomach. Stay sutures are placed and a small stab wound is made between purse string sutures. A gastrostomy tube is inserted and the purse string sutures are tied. The gastrostomy tube is withdrawn through a stab wound in the abdominal wall and stay sutures are placed in the posterior fascia. The abdominal incision is closed. Report 43,831 if performed to facilitate feeding a neonate. Gastrostomy, open, with construction of gastric tube, e.g., Janeway procedure. The physician constructs a permanent gastrostomy for installation of nutrients. After a small midline upper abdominal incision, the physician creates a flap with its base at the greater curvature of the stomach. The flap is converted into a tube by closure of the stomach incision. The tube is brought through the skin surface via a stab wound or tunnel. The end of the tube is everted slightly and sutured to the skin. The abdominal incision is closed with sutures. Hepatotomy, for open drainage of abscess or cyst, 1 or 2 stages. The physician incises the liver to drain an abscess or a cyst, sometimes taking 1 or 2 stages. The physician exposes the liver via an upper midline incision. The cyst is incised and suctioned with care to not contaminate the abdomen with purulent matter. Cultures and pathology are sent in a separately reported activity. The incision is closed. Anorectal myomectomy. The physician removes a muscle tumor or a section of muscle from the anorectum. The physician identifies the anorectal muscle tumor or area of interest. A transanal incision is made through the rectal wall and the tumor or identified area of muscle is excised. The incision is closed by approximating the muscle edges and closing the incision in the rectal lining.